please, I am pumped up today, and you know what? We're going to discuss something very important. I just want to make sure that you can hear me. You can hear me. You can hear me. Where are you? Where are you joining me from? Please, you can hear me. You can hear me. Where are you joining me from? I want to know. I want to know. I want to know. Please, I want to know. I want to know. Where are you joining me from? Please send this link to as many friends as possible. As many friends as possible. Tell them to join us live on YouTube so we can get our MCCQE1 preparation going. You know, it's exciting, and I really Dr. Collins says yes, Ontario. Awesome. Look, I told that the group, our Q1 group, that look, I have a lot to share today. So look, I'm just going to dive in because today we have almost 120 slides to cover. Okay. So I don't know. I'm just hoping the class doesn't go beyond 2 hours. So please, if you are becoming hypoglycemic, kindly tell your friend or your wife or your husband or your child to bring you some juice, because today we're going to dive deep. Please go to our YouTube channel right now. Click on the like and subscribe button. Please click on the like and subscribe button on YouTube right now, and please share this link with as many friends as possible. Okay, please share this link with as many friends as possible. We are diving right in. So we have people join us from Ontario, Canada, of course, Calgary. That is Dr. Kate, Dr. Emmanuel Bellington. Where is that? Is that England? Bellington. Vancouver. Yeah, I heard it snowed in Vancouver this week, and a friend was making so much noise about it. I was like, come on, -8 in Vancouver. We are doing like -30-something in Saskatchewan, right? So, but you know, everyone has how they see things. So good. Dr. Sabine says you can hear me. Let's dive in. Please share this with as many friends as possible. This class is going to be a blast, and I really look forward to it. So let me share my screen. Share screen. Let me see. Beautiful. Let me share my screen. Please, do you see my screen now? Do you see my screen? If you see my screen, type yes, because we need to jump in right away. Do you see my screen? If you see my screen, type yes. And let's go. We have people with Med Talks with Dr. Debola from Nigeria. Wow. Okay, good. So I'm getting the hints that you guys can hear me. You can see me. You can see my screen. Let's go. So approach to newborn assessment. Now, in the objective, it says something very important. Like what we've learned, you know, so far as this particular exam is concerned. It says that it says something very interesting. It says that primary care physicians play a vital role in identifying children at risk for disorders that are threatening to life or long-term health before they become symptomatic. And in most cases, caregivers require reassurance and anticipatory guidance regarding the health of their newborn infant. All right? This is something you want to really pay attention to. And so the key objective is that given a newborn who is presenting for routine assessment, the candidate, that is you, doc, that is you going for the exam, will conduct a skilled and comprehensive assessment to identify any significant abnormalities or risk factors and counsel caregivers on newborn care. And then it goes on to say this interesting thing that given the enabling objectives, given a newborn for routine assessment, the candidate will, number one, list and interpret critical clinical findings, including maternal and prenatal history. So please write this down. In your MCCQE1 exam, you need to know, even though it's MCQs, you need to know what are the pertinent questions to ask on maternal history. So far as perinatal history was concerned, was there any perinatal fever? Was there any intrapartum fever? Did the mother take any medications? Okay. Neonatal history as well. So ABGA score, how to assess ABGA scores. Feeding and elimination, psychosocial history. What is the maternal mental health before they went into deliver? What is the home environment like? Is there any family support? Okay. And systematic newborn physical examination with particular attention to indications of an acute illness. Okay, so how do you notice, like, if a child has jaundice, the hydration status of the child, and screening for important congenital malformations like red reflex, because you want to rule out things like retinoblastoma. You want to check the heart as well. Okay, and then if there's any caregiver concern as well, you want to deal with that. And then now you want to list and interpret critical investigations, including screening tests for acute illness. So serum glucose, screening tests for clinical abnormalities like echocardiogram, genetic testing, bilirubin measurements, okay, and construct an effective initial management plan, including managing any acute illness appropriately, including referral for specialized care if needed, and counseling caregivers regarding breastfeeding and infant nutrition. In fact, today's class is going to focus on that, breastfeeding and infant nutrition. So today we're going to do a very, very, very deep dive into breastfeeding and infant nutrition, okay? And counseling caregivers about routine infant care like umbilical cord care and safety and prevention of sudden infant death syndrome. And discussing with caregivers newborn metabolic screening, okay, and addressing any parental concerns. So these are the enabling objectives for this exam. And there are so many things in there, and you need to know how you're going to deal with this particular key objectives. So today, we're going to spend at least 1.5 hours. So doctors, please, it may go to 2 hours, all right? At least 1.5 hours or 2 hours on this subject of breastfeeding, so that we are able to ace the MCQ1 exam easily. So we're going to start with a question, like what we do. So this is just introduction to breastfeeding. We're going to start with a question. So please, doctors, let me know. Are you ready to roll? Are you ready to roll? If you are ready, just type, yes, I'm ready. I'm ready to roll. I'm ready to roll. And then we can start. I'm going to drop the first question right away. I'm ready to roll. Let me know. I'm ready to roll. I'm ready to roll. I'm ready to roll. Beautiful, 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 beautiful. So, first question. You have a 27-year-old first-time mother who delivers a full-term healthy male infant by spontaneous vaginal delivery. All right? She expresses her desire for exclusively breastfeed for the first 6 months. The neonatologist provides initial lactation support and advises her about the importance of early and frequent breastfeeding. However, she becomes anxious when her milk supply does not seem sufficient on the first postpartum day. Which of the following is the most appropriate next step in managing her concerns? A, recommend formula supplementation to prevent neonatal hypoglycemia. B, reassure her that colostrum is adequate and encourage frequent nursing. C, prescribe a galactagogue to accelerate milk production. D, advise stopping breastfeeding if the infant appears frustrated. And E, introduce complementary solid foods to improve infant nutrition. You think you know breastfeeding? Now let's get into the ring with Dr. Brony and let's see. Okay, look, it looks like so many people are going with B. Dr. Irene, as usual, is going with B. Dr. Benedicta is going with B. Dr. Hope is going with B. Everybody is going with B. And the correct answer is B. So, reassure her that colostrum is adequate and encourage frequent nursing. What do I mean by this? The explanation is that in the first few days postpartum, okay, colostrum provides essential nutrients and immune protection. And milk production increases gradually due to hormonal regulation, and frequent nursing enhances milk supply. So you've got to be able to reassure this mother that colostrum is adequate and encourage her to frequently nurse. So that is the first learning point I want you to take from here. Okay? So formula supplementation is not necessary unless there are clinical indications, such as if the child is dehydrated or the child is hypoglycemic. Okay? And galactogogues are not typically needed in the early postpartum period unless there's documented inadequate milk supply. Then you want to give a galactogogue. All right? And stopping breastfeeding is counterproductive because remember that breastfeeding depends on the milk letdown reflex. So the more the mother is putting the baby to breast, the more the baby is going to suckle and therefore get the mother to produce more breast milk. Doctors, please, I hope you are following. And introducing solid foods before 6 months contradicts the World Health Organization recommendation about feeding for babies. So that is also wrong. So doctors, this is the first question. I'm moving on to the next question. Is that okay? Did the explanation make sense? Can I move on? Please, can I move on? We have so many questions to deal with today. So I want us to go military style. Can I move on, please? Can I move on? Okay, good. Next question. You have a 30-year-old woman with a history of well-controlled hypothyroidism. She delivers a term infant by emergency cesarean section. She intends to breastfeed exclusively, but she expresses concerns about her ability to do so, particularly because her mother and sister had difficulty producing enough milk. She asks if there are any risks that may contribute to insufficient milk production. Insufficient breast milk production, which are the following factors, is least likely to contribute to insufficient lactation. Remember, the question is least likely. Least likely. Least likely. A, cesarean section delivery. B, maternal hypothyroidism. C, early skin-to-skin contact after birth. D, infrequent breastfeeding sessions. And E, maternal anxiety. What's our correct answer? Least likely to contribute to insufficient lactation. Least likely. Okay, so Dr. Mehu says the answer is C, and looks like Dr. Jagdeep also went for that. Least likely, early skin-to-skin contact, all right? Early skin-to-skin contact after birth. So skin-to-skin contact immediately after birth promotes breastfeeding initiation, not reducing it. So what are the other factors which can lead to delayed breast milk production? Cesarean delivery can do that. Maternal hypothyroidism. Doctors, please write this down. We are looking at factors that can reduce milk production. Number one, if the mother goes through cesarean delivery. All right? Look, the energy in the class is just too much. The energy in the class is too much. Everyone is answering. This is beautiful. So early skin-to-skin contact after birth will rather encourage breast milk production, okay? And the factors which reduce breast milk production are cesarean delivery, maternal hypothyroidism, infrequent breastfeeding. So infrequent breastfeeding will reduce more breast milk production, and maternal anxiety, okay? Because maternal anxiety will negatively affect oxytocin release, and because of that, it impairs milk letdown reflex. All right, please. So write these down. After this, like what you did last week, share screenshots of the notes you took. It really encourages me to know that we should do more for the IMJ community. Okay, good. Now, next question. A 34-year-old woman gives birth to a healthy term infant. During the birth hospitalization, she receives counseling about breastfeeding. At her 6-week postpartum visit, she reports wanting to stop breastfeeding, stating, "I just don't think I'm making enough milk." Now, the physician educates her about lactation physiology and notes that over 60% of mothers report insufficient milk supply as a reason for early weaning. Which of the following interventions is most likely to help her sustain breastfeeding? Sustain breastfeeding. A, prescribing a dopamine agonist to enhance prolactin release. B, encouraging continued breastfeeding on demand with proper latch techniques. C, supplementing each feeding with formula to ensure adequate intake. D, switching to exclusive pumping instead of direct breastfeeding. E, delaying introduction of solid foods until 9 months. Delaying introduction of solid foods until 9 months. What's the correct answer? Is it A? Is it B? Is it C? Is it D? Please put in your answers. I'm following your answers. So we have about 151 people live on all our platforms. Please, if we can push this to 200, that would be awesome. Doctors, you have WhatsApp groups, you have Telegram groups, you have Facebook groups, you have friends. Just share the link with them. Just share the link with them. Let them join. Let's study. Don't keep the good news to yourself alone. So what's the correct answer here? The correct answer is B, encouraging continued breastfeeding on demand with proper latch techniques, okay? Because frequent and effective nursing is the most important factor in maintaining milk production. As I told you about the milk letdown reflex, okay? Dopamine agonists suppress prolactin and they'll rather inhibit lactation, not enhance it. And formula supplementation reduces breast stimulation and can decrease milk production. Remember that we want to encourage you to produce breast milk more, right? And exclusive pumping may not be as effective as direct breastfeeding in maintaining lactation, because you rather want the baby to latch onto the breast so that the mother can produce more because of the milk letdown reflex. And complementary foods should be introduced at around 6 months, not 9 months. Okay, so that's another thing. Please remember, if you're going to introduce complementary foods, it should be around 6 months. I like this point Dr. Maria Fernanda Vasquez just put out there. She said, the more suction, the more production. Beautiful. The more suction, the more production. Remember that for your QE1 exam. Next question. A 22-year-old woman delivers a full-term infant and begins exclusive breastfeeding. She expresses concern about whether breastfeeding is sufficient for her infant's long-term health. She asks about the benefits of breastfeeding compared to formula feeding. Which of the following is not an established benefit of breastfeeding for the infant? A, reduce risk of otitis media. We are looking for things which are not an established benefit. Okay, so A, reduced risk of otitis media. B, lower risk of childhood obesity. C, decreased incidence of sudden infant death syndrome. D, increased risk of atopic dermatitis. And E, enhanced immune protection through secretory IgA. What's the correct answer? Is it A? Is it B? Is it C? Is it D? Or is it E? Doctors, don't forget to subscribe to our YouTube channel. Okay? We need to hit 2,000 subscribers. So please, help us to get there so that as many friends as possible can also see what MedCognito is doing. So we are currently at 1,900 subscribers. Let's move it to 2,000 subscribers, all right? We are doing this with you because the more you're able to share this with other people, the better the channel will grow. And other people will also get to benefit from it for their MCCQE1 exam. So what's the correct answer? It looks like everybody is going for D. So what are the established benefits of breast milk, breastfeeding? Let's use this as a learning tool. Please write these down. Breastfeeding reduces the risk of otitis media. Number 2, breast milk reduces the risk of childhood obesity. Number 3, breast milk or breastfeeding reduces the incidence of sudden infant death syndrome. Number 4, breastfeeding enhances immune protection. All right. So the only answer which is wrong there is D. 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 Now, Dr. Sabine just put something here. She says it should be decreased risk. No, the question is, which of the following is not an established benefit Which of the following is not an established benefit of breastfeeding? Okay, so we are looking for all the established benefits and which of them does not help. Okay, yeah, we are looking for all the we are looking for all the benefits and which one does not fit in. All right, which of them does not fit in? Okay, so let's continue to the next one. I think someone is saying I should go back to the previous question. Dr. Beverly Aji. Okay, so I'll go back. Doc, this one, is this question you're talking about? Dr. Beverly, is this question you're asking about? Okay, I'll just move on to the next question then, or the next point. So, breastfeeding is associated with lower risk of atopic dermatitis, particularly in infants with family history of atopy, not increased risk. Okay, so lower risk of otitis media is a documented protective effect of breastfeeding. Lower childhood obesity risk is linked to metabolic and hormonal regulation, and it is good if the child is breastfed. Breastfeeding reduces the risk of SIDS due to improved arousal responses, okay? Sudden infant death syndrome. And secretory IgA in breast milk provides enhanced immune protection, all right? So this is going to be a very quick introduction to breastfeeding, and I'm just going to do a quick deep dive into it. So human milk is the optimal source of nutrition and protection for newborns, providing numerous benefits for both the infant and the mother, okay? And breastfeeding is strongly recommended by, major health organizations like the World Health Organization, the American Academy of Pediatrics, even the Canadian Pediatric Association as well. Now, when to introduce complementary feeds, because there was a question on that. We introduce complementary feeds after 6 months. After 6 months. And usually when you introduce the complementary feeds, you want to continue breastfeeding as long as mutually desired by the mother and the child. Okay? After 6 months. And you want to breastfeed for potentially 2 years. Okay? And some people can go beyond that, but at least potentially 2 years. That is a great target for many mothers to reach, but many people are not able to reach it because of various factors, maternal fatigue, work, and all sorts of things. Okay, breastfeeding is the optimal feeding method for newborns, and healthcare support is crucial if you're going to initiate it. That's why I was asking all those questions initially. Okay, and extended breastfeeding has accumulated benefits. It leads to updated recommendations advocating continued breastfeeding beyond 2 years when mutually desired. So if the mother can go beyond 2 years, it's also somehow encouraged. But at least if they're able to hit the 2-year mark, that is powerful. Okay. Now, we're going to do some questions on successful breastfeeding. Some questions on successful breastfeeding. So let's dive into it. Successful breastfeeding. You have a 26-year-old woman who delivers a term infant by cesarean section under spinal anesthesia. The baby is vigorous, has normal Apgar scores, and is placed in an open warmer while the surgery is completed. The nurse asks when the mother should start breastfeeding. Which of the following is the best course of action? So a patient who has just had cesarean delivery, when is the best time for them to start breastfeeding? A, initiate breastfeeding after the mother is transferred to the postpartum ward. B, encourage immediate skin-to-skin contact and assist with breastfeeding as soon as possible. C, provide formula feeding for the first 24 hours to allow the mother to recover. D, delay breastfeeding for at least 6 hours due to residual anesthesia effects. E, allow the baby to self-latch once the mother expresses readiness without active support. What is your answer? What is your answer? Looks like a lot of doctors are cracking this breastfeeding code today, which is very, very good. Okay, so the answer is B. Even when the patient has had cesarean, encourage immediate skin-to-skin contact. immediate skin-to-skin contact and assist with breastfeeding as soon as possible. With A, why is A wrong? Delaying breastfeeding reduces the likelihood of successful latching and continued breastfeeding. So that's why you don't want to delay it. And formula feed should only be given if it is very necessary, like the child is dehydrated, like the child is hypoglycemic, okay? And delaying breastfeeding due to anesthesia is unnecessary. Spinal anesthesia does not contraindicate early breastfeeding. So you realize that as the class goes on, they'll get to a point in time where I'll be talking about contraindications to breastfeeding, medications which are not good for a breastfeeding mother to take, right? So, and then E is waiting for self-latching without assistance. This may result in missed early feeding cues. So that's very dangerous as well. Okay, good. Next question. Today we're going to finish breastfeeding, and then we know that we are done. That's why I set so many questions and dealt with all the facets of breastfeeding. So let's get into this. So it says that you have a 29-year-old woman who delivers a healthy term infant and is eager to breastfeed. However, she reports extreme fatigue and asks the nurse if the baby can be taken to the nursery overnight so she can rest. Which of the following is the best response by the nurse? A, rooming in is optional. You can send the baby to the nursery for formula feeds. B, your baby should stay with you 24 hours a day, but formula can be given if you feel exhausted. C, rooming in helps breastfeeding success, but we can assist with baby care while you rest. D, breastfeeding should be scheduled every 4 hours, so keeping the baby in the nursery is fine. E, exclusive breastfeeding means keeping the baby with you at all times without assistance. I can see that there's a battle between B and C. There's a battle between B and C. B and C. B and C. There's a battle going on there between B and C. Now, what's the correct answer? The correct answer is C. Rooming in helps with breastfeeding success, okay? But we can assist with baby care while you rest. So rooming in is like, keeping the baby in the same room as the mother. Now, rooming in helps the mothers to recognize feeding cues, because there are things that the child will do or the baby will do which will help the mother to know that the baby wants to feed. And when you room in the baby with the mother, it increases breastfeeding success and it promotes bonding. Okay, so you should avoid formula feeding unless it is medically necessary. And scheduling feeding every 4 hours is incorrect. Breastfeeding should be on demand. On demand. So far as the baby shows any cue that it wants to breastfeed, feed the baby. Okay, on demand. And then mothers may need rest, but assistance should be provided without removing the infant from the room. So you keep the baby in the room so that the mother can be able to pick up, the cues that the baby wants to breastfeed. Okay, next question. You have a 35-year-old mother who is struggling with breastfeeding her newborn. She states, I don't think my baby is getting enough milk because she's crying often. The baby has had adequate wet diapers and weight gain, but the mother is concerned. Which of the following best explains the baby's crying and need for frequent feeding? A, the infant has colic and needs formula supplementation. B, the baby is likely dehydrated and requires IV fluids. C, the mother should recognize feeding cues and breastfeed on demand. D, the baby should be on strict schedule, feeding every 3 to 4 hours. E, the mother should stop breastfeeding and switch to bottle feeding. Doctors, what's your answer? For today, the breastfeeding, we're just going bam, 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 bam. All right. So the correct answer is C. All right. Like what everyone is saying. The mother should recognize feeding cues and breastfeeding on demand. Okay. So proper breastfeeding plan recommends feeding on demand. Like what I said, not routine, like not putting a child on a schedule every 3 to 4 hours. No. So far as the child shows some feeding cues, you must breastfeed. And you must learn for the MCCQE1 how to identify feeding cues in a newborn baby. Now, a 22-year-old mother of a healthy newborn is eager to breastfeed, but is considering introducing a bottle for some night feeds and pacifiers to soothe her baby. She asks if these will interfere with breastfeeding. Oh my goodness, someone just said something very funny. Dr. Farah Khan says, all the mothers are attending lectures and solving problems with their own experiences. That's true. If you're a mother, you'll be able to pick a lot of these things up. So, a 22-year-old mother of a healthy newborn is eager to breastfeed, but is considering introducing a bottle for some night feeds and pacifiers to soothe her baby. She asks if these will interfere with breastfeeding. What's the most appropriate response? A, it is best to avoid bottles and pacifiers initially, as they may interfere with breastfeeding. B, giving a bottle at night will not affect breastfeeding as long as you nurse during the day. C, pacifiers help with infant soothing and should always be used after each feed. D, you can alternate bottle feeding and breastfeeding without any risk of nipple confusion. And E, pacifiers and bottles are necessary to prevent excessive crying and hunger. I like the confusion which is setting up now, because now we are getting into deep stuff, right? Now you can't just use maternal knowledge. You need to know your stuff to get deep into it. Okay, so what is the correct answer? Is it A? Because I can see some people are torn between A and C. I can see that there's a battle between A and C. Doctors, we have hit 181 people. I want us to hit 200. Watching live. Okay, I want us to hit 200. So please keep sharing the link, keep sharing the YouTube link, and don't forget to click on the like and the subscribe button as well. Beautiful. Let's keep going. So, what's the correct answer? The correct answer is A. The correct answer is A. It is best to avoid bottles and pacifiers initially, as they may interfere with breastfeeding. In fact, when you look at the recommendations on bottles and pacifiers, the recommendation is that mothers on the risk of bottles and pacifiers, which can cause nipple confusion, and it can affect proper latching, because the way the bottle feels in the mouth of the baby is totally different from the way the breast nipple feels in the mouth of the baby. Okay, so bottle feeding and pacifiers may disrupt effective breastfeeding establishment and should be avoided in the early weeks. As the class goes on, what I will do is that I will also let you know the appropriate time to introduce a pacifier and what is the benefit of a pacifier. Okay, the appropriate time to introduce a pacifier and what's the benefit of a pacifier. So, okay, so someone says something here. Let me read the question. It says, my problem with C is always be used and doesn't sound right. Okay, so I think Dr. Emmanuel Nwobu has just brought up something which is very, very important. Remember that if you have time, when you are done with this class, go back to the YouTube channel or go back to our Facebook channel, or if you are in our WhatsApp group as well, you can go there. You will see that we talked about tricks on how to solve MCQs. And that is one thing we talked about, that when you see things like always, never, be very careful. And for those who want to join the WhatsApp group, I will look for the link and drop it in the comment section right now, because it looks like some people want to join the WhatsApp group. So did you know we have a WhatsApp group? Do you know we have a WhatsApp group? I will share the link right now because I think some people want it. So let me share the link. Yeah, just click on the link right now and join our WhatsApp group. Okay, so I'm just sharing the link. So you can join our WhatsApp group right now. Can join our WhatsApp group. I'm going to share the link right now so that before the class continues, because it helps you to get a lot of quick announcements. Okay, because if it's on your phone, you don't have to wait to see it on Facebook. Okay, so I am sharing the link. I'm sharing the link to our WhatsApp group. Please click on it. This is a MedCognito WhatsApp group. Okay, and you can share it with as many friends as possible. I'm sharing the link in the comment section. Please let me know if you receive it. Okay, good. Because someone says that, Dr. Bonnie, I didn't know you have a WhatsApp group. Sorry, I have a WhatsApp group. So you can just join it, because all the announcements and everything, and then you can also get direct access to me as well. Okay, so the correct answer is A. All right, we've already learned it, so that is it. Okay, so let's do a deep dive into steps to successful breastfeeding. Steps to successful breastfeeding. Doctors, please, is the class making sense so far? I want to make sure. Is the class making sense so far? Is it making sense? Is it helping? Is it, clarifying some concepts? Please. Is it, before I go into the deep dive, is it making any sense? I want to know. The questions and the answers, and then we going down. I want to know. Okay, good. Dr. Sabine says yes. Okay, so now, deep dive. Successful breastfeeding, the hospitals must have policies, right? Remember that the MCQ1 is not only about critical clinical knowledge, it's also about public health recommendations and everything. So the hospitals must have policies, and you must comply with International Code of Marketing of Breast Milk Substitutes and relevant World Health Assembly resolutions, okay? And hospitals must maintain a written infant feeding policy that is communicated to staff and the parents of the babies, and as well establish ongoing monitoring and data management systems. Number 2, hospitals must conduct staff training and competency training, okay, and ensure staff possess adequate knowledge, competence, and skills to support breastfeeding. These are things that you see in all Canadian hospitals. Number 3, education for pregnant women and families. You've got to discuss importance and management of breastfeeding with expectant mothers and their families. That's very, very important. And you also want to encourage skin-to-skin contact and early initiation of it, because when there is skin-to-skin contact, it supports immediate and uninterrupted skin-to-skin contact after birth. And it encourages mothers to initiate breastfeeding as early as possible. So whether the mother had a cesarean or not, skin-to-skin contact is very, very important. And supporting breastfeeding and managing challenges. You want to assist mothers initiating and maintaining breastfeeding. And you want to help address common breastfeeding difficulties, okay? And exclusive breastfeeding. Avoid giving newborns any food or fluids other than breast milk, unless it is necessary for medical reasons. So doctors, that's also very important for your MCQ1 exam, okay? And rooming in and mother-infant bonding, we talked about that in one of the questions. It enables mothers and infants to stay together 24/7. If they are all in the same room, it really, really helps. Okay, so what are some of the other steps for successful breastfeeding? Mothers must recognize infant feeding cues. Like, what are the things that the baby should do, which should let the mother know that, the baby wants to feed. So you need to educate the mothers on how to interpret and respond to their baby's hunger. Okay? And counseling on artificial feeding risks. Inform mothers about the risk of bottles, the risks of teeth, and the risks of pacifiers. So these are all things you need to master for your MCQ1 exam. And coordinated discharge and continuous support. You need to plan discharge so parents have ongoing access to breastfeeding support. So before we move on to deeper dives, I want to remind you that initially it was advertised that we'll be doing our second med drill on February 18th. Now it's clashed with the NAC OSCE class, and we have some MCQ1 candidates who are also taking NAC OSCE. So we are moving into February 19th. February 19th. Okay? So if you are planning on attending that med drill, In psychiatry, it will be on February 19th, not February 18th. We had the first one on February 10th, where we went through 32 topics in 3 hours. So February 19th, we'll do the rest, and then we are done with med drills for psychiatry. All right. And this is like my time with candidates. You know, it's an intimate time where we go through deep stuff that they want to master for the MCQ1 exam. The last one, we did 32 topics. This other one, we can also do the same. Dr. Katie is asking, when can we expect mocks? Mocks are starting in March. Mocks are starting in March, and to go full swing towards the exam. Okay. Now, what were the candidates saying after the med drill? Thank you, Dr. Boni. Wonderful session. Thanks a lot, Dr. Boni, for the wonderful session. Blessed to have a wonderful teacher, Dr. Boni. Thank you so much, Dr. Boni. It was an amazing session. Thank you so much, Dr. Boni, for the amazing session. I'm truly grateful to have such an inspiring teacher like you. Wishing you all the best, and many may you be blessed abundantly. You know, thank you, Dr. Boni, for a wonderful session. So many of those. Someone said this, and for me, it was very important. It says, thank you for such an amazing section, Dr. Boni. So many concepts became clear, especially around diagnosing schizophrenia, schizoaffective disorder, borderline personality disorder. I used to find it so confusing before, but your way of teaching made everything so much easier to understand. You are truly an amazing mentor, and I appreciate your guidance. Doctors, we are here to help you. If you really want me to help you, I'm here. I will drop my phone number at the bottom of the screen. Please call me right away as soon as the class is done. Or you can even text me as the class is going on, so that as soon as the class is done, I'll get in touch with you. All right? And I really prefer that you contact me by WhatsApp. +1 306 891 5649. +1 306 891 5649. Just send a WhatsApp right away. After the class, I'm going to call you. So let's get into it. Typical newborn behaviors during skin-to-skin care. Typical newborn behaviors during skin-to-skin care. So let's go into some questions right away. Number one, you have a 26-year-old woman who delivers a full-term, healthy infant through an uncomplicated vaginal delivery. The baby is placed on her chest for immediate skin-to-skin care. Over the next few minutes, the newborn stops crying and begins small head and shoulder movements, followed by rooting and mouthing behaviors. Which of the following correctly describes the sequence of behaviors exhibited by this infant? So let me take you through the question again. A 26-year-old woman delivers a full-term infant. Healthy infant by uncomplicated vaginal delivery. Okay? I continue. The baby is placed on her chest for immediate skin-to-skin care. Over the next few minutes, the newborn stops crying and begins small head and shoulder movements, followed by rooting and mouthing behaviors. Which of the following correctly describes the sequence of behaviors exhibited by this infant? A, birth cry, relaxation, awakening, and activity. B, birth cry, crawling, suckling, familiarization. C, awakening, sleep, activity, suckling. D, relaxation, familiarization, birth cry, to sleep. And then E, crawling, suckling, awakening, and birth cry. And you realize that you've got to really know what each of these terms mean in order to be able to answer this question correctly. You've got to be able to know what each of these terms mean in order to be able to answer these questions correctly. You've got to know what each of these terms mean in order to be able to answer these questions correctly. So what is the answer? I see a lot of people going with A, and some are going with B, Some are also going with C. Okay, so I'll tell you what the answer is. The answer is A. So they go through birth cry, relaxation, awakening, and activity. So what is birth cry? And there's a whole, I'm going to do a whole lecture on that, like at the bottom somewhere. So birth cry occurs immediately after birth. So that, that cry that the baby will, like the way they'll cry out, and it's because, as soon as they are born, they do the birth cry, okay? Because it expands their lungs. Now, after birth cry, there's relaxation, where the baby will exhibit relaxed hands and no active movement. So they'll cry, you see they'll move their hand like that, and then after that they'll relax. And then they go in through the awakening phase. It involves small movements of their head and their shoulders, okay? And then they move into the activity phase, where there is mouthing, suckling, and rooting, which prepares the infant for breastfeeding. So let me take it again. Please write these down. They go from birth cry to relaxation to awakening, which is the small movements of the shoulder and the head. And then they move to activity, which consists of mouthing, suckling, and rooting, which prepares the infant for breastfeeding. So if I should go back to the question again, anywhere birth cry does not come first, so D and E, that is already wrong, right? And then C is also wrong. Birth cry must come first, but birth cry must come, and then there must be relaxation, and there must be awakening, and there must be activity. All right? Okay. Don't worry. I'm going to do a whole, I'm going to break all those principles down. So let's go through this other question. You have a 30-year-old first-time mother expresses concern when her newborn, during skin-to-skin care, starts moving in small bursts towards her breast, licking and massaging the nipple before latching. She worries that her baby is having trouble feeding. Which of the following is the best response by the clinician? Which of the following is the best response by the doctor? A, there's an abnormal feeding pattern. We should supplement with formula immediately. B, your baby is displaying normal behaviors. Crawling and familiarization are natural before suckling. C, these movements indicate oral aversion, and we should evaluate for feeding difficulties. D, you should manually express colostrum to assist your baby, as newborns cannot reach the breast on their own. E, infants should latch immediately without crawling or licking. This delay suggests poor feeding ability. What's the correct answer? Sorry, for those who are still asking for the link to our WhatsApp group, while you're answering this question, I'm dropping the link. Click on it and just join us, okay? Please. You can just click on it and just join that WhatsApp group, so that you can have us on your phone as well. So that if there's any quick thing I want to touch base on with you, we just do that. So please click on it and then join the WhatsApp group. Okay. So what's the correct answer? I see a lot of people are going with B. Dr. Chioma went for B. Dr. David in Kasahama also went for B. Dr. Sabiha went for B. And the correct answer is B. So your baby is displaying normal behaviors. So when a baby is crawling towards the breast, and it's crawling and familiarization are expected behaviors, because the baby is not used to it, right? Where the infant moves towards the nipple, will lick the nipple and touch the breast before latching. This is normal infant behavior. Okay, so formula supplementation is unnecessary, and oral aversion is not correct, because these behaviors are part of normal newborn physiology. Okay, and manually expressing colostrum is not necessary unless the infant has true difficulty with latching, like issues like cleft lip and cleft palate and all those things, right? And then immediate latching is not required, as the baby naturally progresses through phases. So that's what I'm trying to say. you have to know the phases the baby goes through before they latch onto the nipple to breastfeed. Okay. Now, next question. Next question. A 29-year-old woman undergoes an uncomplicated cesarean section and expresses her desire to breastfeed. However, the newborn is separated for a routine weight check and placed in a warmer for 30 minutes before being returned to the mother. Upon return, the baby appears sleepy and has difficulty latching. What's the most likely explanation for this infant's behavior? A. The baby is experiencing neonatal hypoglycemia. B. Separation from the mother has disrupted the newborn's natural feeding sequence. C. The infant is in the crawling phase and will eventually latch. D. The baby likely has an undiagnosed neuromuscular disorder. E. The infant should have been given glucose water to prevent fatigue. What's the correct answer? So Dr. Shayna went for C, that the infant is in a crawling phase. Dr. Benedicta went for B, separation from the mother has disrupted. Dr. Ben Ogu also went for B. Dr. Jagdeep went for B as well. The correct answer is B. Please, the correct answer is B. Because of the separation from the mother, it has disrupted the newborn's natural feeding sequence. All right? And skin-to-skin care should be uninterrupted because it allows the baby to progress naturally. Remember, we talked about the birth cry, the relaxation, the awakening, where they move their shoulders, the activity, the crawling, and then the suckling. So please, write these processes down. Birth cry. It goes then to relaxation. Then it goes to awakening. Then it goes to activity. Then it goes to crawling. Then it goes to suckling. So please, you've got to write these down. And I want to see you after that. Share your, share it with me. Okay? Share your notes. Just a screenshot of, your learning environment. Just share something with me so that we can keep the revolution going. We want to make sure that as many of us as possible get over the finish line so far as this exam is concerned. So, hypoglycemia is unlikely in healthy full-term baby who was just born, okay? And the baby is likely past the crawling phase and is now fatigued. So the baby is still not in the crawling phase. And a neuromuscular disorder is unlikely given the fact that there's a normal behavior prior to separation. The child had normal behavior prior to separation, right? From the mother for the 30 minutes. And glucose water is not recommended because it may interfere with breastfeeding. So that's also a wrong answer. Next question. You have a 34-year-old gravida 2-para-1 mother expresses concern that her newborn is not suckling effectively, despite spending time in skin-to-skin contact. The nurse observes that the baby went through birth cry, relaxation, awakening, and activity stages, but never attempted crawling, familiarization, or suckling. Which of the following is the most appropriate next step? So you now have a baby who is going through the initial phases, but did not complete the phase. Which of the following is the most appropriate next step? A, continue observing as the baby will eventually latch independently. B, provide formula supplementation to prevent dehydration. C, assess for neurologic dysfunction or prematurity related feeding issues. D, introduce a pacifier to encourage suckling reflex development. And E, perform a gastric lavage to rule out esophageal atresia. So what's the correct answer? This mother is concerned. Baby is not suckling effectively. Despite she's spending time in skin-to-skin contact, the nurse observes that the baby went through birth cry, relaxation, awakening, and activity stages, but never attempted crawling, familiarization, or suckling. Which of the following is the most appropriate next step? And the answer is you want to assess for neurologic dysfunction. Beautiful. So, look, Dr. David, please, you want to check your answer, Dr. Mutombo. But looks like a lot of people got it. That's beautiful. So, you want to assess for neurologic dysfunction. right? A healthy newborn should progress through all the stages of feeding, including crawling, familiarization, and suckling. So in this baby who went through birth cry, relaxation, awakening, activity, and could not go through the crawling and familiarization and suckling phase, chances are that there's a problem. And so you want to assess for any neurologic dysfunction or prematurity related feeding issues. Please, you want to do that. You want to do that. You want to do that right away. You want to do that. Okay? And esophageal atresia presents with drooling and regurgitation, not failure to crawl or latch. So that is far-fetched, right? So if you have a newborn baby who goes through some initial activity but cannot complete everything, there's a problem. Okay, so a mother expresses concern that her newborn falls asleep soon after brief suckling and does not feed for extended periods. She worries that her baby is not getting enough milk. What's the most appropriate advice? A, this is normal newborn behavior. Babies sleep after suckling. B, your baby should not fall asleep after feeding. This may indicate neonatal hypoglycemia. C, this behavior is abnormal. We should introduce formula feeds. D, the baby needs to be actively woken up and stimulated for every feed. And E, let the baby sleep undisturbed. Newborns do not need frequent feeding in the first few days. What's the correct answer? Dr. Amaze John went for C. Dr. Dodumbose Bolembo went for A. Others are going for different answers. Some are going for A, some are going for... Wow. People are sending me screenshots of what they are doing. Please, kindly send me screenshots. Kindly send me screenshots. It's beautiful. It's beautiful. It's beautiful. I love it. Dr. Jagdeep sent me something. Dr. Riosote also sent me something. Please send me some screenshots on the phone right now, okay? Please send me some screenshots. It's beautiful. I'll share them in the WhatsApp group. This is awesome. 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 Beautiful, 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 beautiful. So please, for the QE1, remember that we need to learn all these principles very, very well. Okay. So what is the correct answer? The correct answer is A. The correct answer is A. And looks like the mothers are getting the answers correct more than the fathers. The mothers are getting the answers correct more than the fathers. Okay. The mothers are getting the answers correct more than the fathers. So sleeping right after meals is normal. Dr. Titi also sent me a screenshot. Sleeping right after meals is normal. And babies sleep after suckling. So answer is A. Okay. Sleeping after suckling is normal behavior. It's the final stage of newborn feeding sequence. So you've got to know that, the feeding sequence, the feeding sequence, the feeding sequence. And how can a baby who has just breastfed become hypoglycemic? So that's not right. And formula supplementation is unnecessary unless there are signs of poor feeding. Okay. And waking the baby aggressively is unnecessary as well, unless they fail to meet feeding goals. That's when you want to wake them. And as well as newborns require frequent feeding every 2 to 3 hours. So letting them sleep too long between feeds may cause dehydration. That is not necessary. Remember that we said that newborns need to feed on demand. So what does each word mean? And then what is the sequence? So when a newborn is born, funny, right? When a newborn is born, they go through birth cry. So please, this one, I'll take my time so you can take notes, or if you like, you can even take a screenshot. So they go through birth cry, okay? And then the birth cry is what occurs immediately after birth, because then it helps to expand their lungs, okay? And then they go through relaxation, where the infant exhibits relaxed hands without mouth movements. And then they go through awakening, which is small head and shoulder movements. Doctors, please don't miss this sequence. Okay, and then they go through activity where newborn mouths they suckle and they exhibit routine movements, and then they go through a period of rest. Yes, I'm teaching. Okay, go upstairs. I'll join you after the teaching. Okay, I'll join you. Okay, say hi to everybody. Say hi to everybody. Say hi. Say hello. Okay, good. Say hello. Okay, Isabel, you to come and say hello to everybody, and then you can go. Say hello. Hello. Okay, good. All right, so now you can go. So, doctors, these guys are worrying me down here. Okay, so they just wanted to say hi to you. Okay, so please remember that the baby will go through birth cry. Okay, so these are the people I teach with, my two little girls. Okay, so they just said hi. So they go through birth cry, then relaxation, then awakening, then activity. Okay, where the newborn mouths and suckles and exhibits routine movements, and then they rest. Okay, usually they have rest between each stage, and then they do what we call crawling. So doctors, please note all these. They do what we call crawling, where the infant moves towards the breast with short periods of action, and then they go through familiarization, where the infant will then lick, touch, and massage the breast, and then they suckle, and after suckling they sleep. Okay, after suckling they sleep. So doctors, let's go through it again. So they go through the birth cry. Okay, they cry. So please, I really want to see you send me a screenshot of this process, because if you miss it, there's trouble. Okay, so they go through the birth cry. It helps to expand their lungs, and then they go through relaxation, where they have relaxed hands, and then they go through awakening, where they have a small head and shoulder movement, and then they go through what we call activity. The newborn mouth, like they make movements with their mouth. Okay, and then they will go through a period of rest in between the stages. Then they go through crawling. Crawling is not like, as we know, it's they crawling on their hands and their knees. No, crawling in terms of they are moving their head towards the breast with short periods of action. Okay, and then they familiarize, because remember, this is a newborn baby. Then they familiarize themselves with, like, the breast, the nipple, where they lick, they touch, and they massage the breast, and then they suckle, and after suckling they rest. So please, you have my phone number, 306-891-5649. Send me, from this to that, because if you get this right, then no question should be able to beat you with that. Okay, beautiful. I'm getting a lot of stuff, so that's very good. Okay, so let's move on. Doctors, did that make sense? Oh, okay. Somebody says you are doing a wonderful job spending your precious Sunday with us. Sure, doctor. After that, we'll go and spend it with the family as well. Okay. And then someone also says our future doctors. Sure. So please, doctors, did it make sense? Like the stages from newborn, birth cry, all the way to sleep after breastfeeding. Did it make sense? Beautiful. I'm getting a lot of wonderful WhatsApp messages, and I'll share them in the WhatsApp group. So if you're not in the WhatsApp group, please make sure that you are in it right away. Okay. All right. So what are factors that lead to infrequent breastfeeding? Let's go through some questions. You have a 33-year-old woman with a history of breast reduction surgery who presents for her newborn 2-week well baby visits. She's been exclusively breastfeeding, but is concerned that her baby is not gaining weight appropriately. She reports frequent nursing, but her baby seems unsatisfied after feeds. Examination shows a well-appearing infant with weight gain, below the expected percentile. Which of the following is the most appropriate next step in management? A, reassure the mother and continue exclusive breastfeeding. B, start formula supplementation and discontinue breastfeeding. C, encourage breastfeeding, monitor weight gain, and use pumping after feeds. D, recommend stopping breastfeeding due to permanent glandular damage. And E, prescribe a dopamine agonist to increase prolactin release. What's the correct answer? Doctors, what's the correct answer? What's the correct answer, doctors? Some are going for C. Oh, Dr. Ebube says ZC. Z. Dr. Ebube, is that a typing error or something? Okay, so the correct answer is C. C. You want to encourage breastfeeding, monitor weight gain, use it, and use pump after feeds. Okay. Now, this is the issue with breast reduction surgery. It's especially with the free nipple technique, it can impair milk production due to glandular loss. Remember that if the female goes through breast reduction, some of her breast glands will be taken off, right? And so that can affect it. Now, optimizing breastfeeding techniques and pumping after feeds can stimulate milk supply, okay? Because you want to just make sure that more milk is being supplied. Now, exclusive breastfeeding without monitoring may lead to failure to thrive, because don't forget that this baby's weight is already below the percentile already. So you want to be very careful. Number 2, stopping breastfeeding entirely is unnecessary, and supplementation should only be used if medically indicated. So you realize that when it comes to principles of breastfeeding, we don't really push for supplementation that much. You want to encourage, natural breastfeeding. But because this patient has had breast reduction surgery and there's some glandular loss after the breastfeeding, and because the baby is not gaining enough weight, you want the mother to still pump so that they can give more breast milk to the baby, okay? And not all breast surgeries cause irreversible damage. Glandular tissue function varies. So you can have somebody who had like a breast biopsy. That is not going to affect breastfeeding. But somebody who had some like breast reduction, because they may take away some of the breast glands, that may affect, where breast milk can be produced from, okay? And dopamine agonists suppress prolactin, rather reducing milk production. Let's go to the next question. You have a 35-year-old gravida 3 para 3 woman who presents 4 weeks postpartum with concerns about low milk supply. She reports fatigue, cold intolerance, and difficulty losing weight despite adequate caloric intake. She also had severe postpartum hemorrhage requiring transfusion. Her newborn is below the expected weight percentile. Which of the following is the most likely cause of her lactation failure? A, polycystic ovarian syndrome. B, retained placental fragment. C, Sheehan syndrome. D, gestational diabetes mellitus. And E, chronic stress. 4 weeks postpartum, low milk supply, fatigue, cold intolerance, difficulty losing weight, severe postpartum hemorrhage requiring transfusion, and the newborn is below the expected weight. What is the most likely cause of her lactation failure? A, polycystic ovarian syndrome. B, retained placental fragments. C, Sheehan syndrome. D, gestational diabetes mellitus. And E, chronic stress. Good, Dr. Henry. Good. So it looks like everyone is going for C. And C is correct. Sheehan syndrome is pituitary infarction. So look at, what I gave you. Due to severe postpartum hemorrhage And that is what has led to the hypoprolactinemia and the lactational failure. And that is also what is leading to, the signs of hypothyroidism, right? Sheehan syndrome. So Sheehan syndrome, look out for Sheehan syndrome in that patient who bleeds a lot after delivery and maybe may need blood transfusion. It can lead to pituitary infarction. And remember that the pituitary gland is responsible for so many things, right? It may lead to pituitary infarction. All right, doctors, do you still have strength? Do you still want us to keep going? Do you still want us to keep going, please? Do you have enough strength? Do you want us to still keep going? Maternal factors that may delay breastfeeding. Okay, so let's look at some maternal factors that can delay breastfeeding. Breast surgery. And remember that breast reduction may lead to low milk production, especially if the nipple-free technique was used. Breast augmentation may or may not impact milk supply. So breast reduction may lead to low breast milk production because some of the breast tissue may be taken off. But breast augmentation, maybe when they put silicone or something, may not impact it. And breast biopsy is unlikely to affect milk production. Okay, so the management is that you want to optimize breastfeeding technique, monitor the infant's weight, and use pumping if necessary. Okay, supplementation may be considered if weight gain is inadequate. So know the kind of breast surgery which can lead to low breast milk production. Know the one which will not affect breast milk supply. Breast reduction may lead to low milk production because there will be loss of some glands. Okay. What about nipple conditions? We are looking at maternal factors that may delay breastfeeding. Okay. Nipple condition. Sore nipples may result in infrequent feeds. So because if the mother is experiencing pain, it may lead to infrequent breast emptying. Okay. And management, assess and manage nipple pain, optimize latch, and continue breastfeeding to stimulate milk production. And then medications. Please, this one, I need you to write it down. I need you to write this one down. Please write it down. Send me a screenshot as well. Write this one down. Send me a screenshot on +1 306 891 5649. +1 306 891 5649. Please send me a screenshot. I'm going to drop the WhatsApp link again. What are medications which can lead to decreased milk production? Medications which can lead to decreased milk production. Number 1, high estrogen oral contraceptive pills. Okay, if you want to find out how to join the WhatsApp group, click on the link. I've put the link in the YouTube and the Facebook conversation. Okay, medications that can lead to decreased milk production. High estrogen oral contraceptives. That's number 1. Please write this down. Number 2, pseudoephedrine. Number 3, nicotine. Number 4, diuretics. Number 5, antihistamines, high dose antihistamines. Number 6, aripiprazole. Number 7, high dose steroids. Number 8, excessive alcohol consumption. Dr. Iman Osman also sent me a screenshot of what she's doing. That's great. Okay, so maternal factors that may delay breastfeeding: high estrogen oral contraceptives, pseudoephedrine, nicotine, diuretics, antihistamine, aripiprazole, high dose steroids, excessive ethanol consumption. Management is you want to optimize technique, consider alternative medications, okay, and refer to reliable lactation medication resources. So this one for your MCCQE1, please know the medications that can delay breastfeeding. Please, this one is very important. Okay, next one, hormonal factors that can also delay breastfeeding. So remember, maternal stress can do that. Remember, obesity can do that. Remember, preeclampsia can do that. Remember, hypertension can do that. Diabetes, polycystic ovarian syndrome, and high androgen levels. These may delay full milk production. So we've learned medication factors. We are learning maternal factors, pituitary insufficiency like Sheehan syndrome, and retained placenta can also impact lactation. Okay, retained placenta and Sheehan syndrome. These can also affect milk production. And then other causes like, insufficient breast tissue due to congenital glandular developmental issues. So maybe if the mother herself had some congenital breast gland issues. So please, doctors, I want to see it. Send me a screenshot. Medications. Write it down with your pen and paper. Medications which can affect it. Maternal factors. Medical conditions which can affect breastfeeding and delay breastfeeding. Okay, now let's look at infant-related factors. Now that we've looked at factors from the mother, let's look at factors from the infant. All right? I hope you're tracking with me. So, prematurity. Prematurity. Doctors, please write it down. Prematurity. Prematurity is one of them. Next one. Ankylosing. That is tongue tie. Tongue tie. Ankylosing. Then neuromotor delay, because they need the strength to be able to latch onto the breast and breastfeed, right? And sucking and swallowing disorders as well as congenital malformations like cleft lip and cleft palate. These are the infant-related factors. So we've looked at the maternal-related factors. We are looking at the infant-related factors. Now let's look at the mother-infant factors. So we looked at mother alone. Now we've looked at infant alone. Now we are looking at mother and infant. So mother-infant factors, delayed breastfeeding initiation. So like that question where the mother had a cesarean, the nurse took the baby, put the baby under a warmer for like 30 minutes. Okay. And then mother-infant separation for whatever reason. Maybe the infant was so sick or the mother was so sick that they couldn't bring them together. And then poor latch. Okay. So maybe the baby is unable to hold on to the mother's nipple. And infrequent feeding, as well as one-sided feeding. Maybe they are feeding from just one side, and so they empty the breast, and then they go to that side of the breast, and they can't get any breast milk. Meanwhile, they need to feed on the other side, and they can't. Right? So we've looked at maternal factors, we've looked at infant factors, and we've looked at both maternal and infant factors. Doctors, are we all tracking together, please? I want to know, are we tracking together? Are we tracking together? Are we tracking together? Please, I want to know. Are we tracking together? Ooh, you see, somebody is even converting it to French. This is beautiful. I have one candidate who is converting it to French. I'll share the link. I'll share the screenshot in the group so that you see it. Someone is converting it to French. Okay, so I've shared it in a WhatsApp group. So please, doctors, are we good? We've looked at maternal factors. We've looked at infant factors. Now we are looking at maternal infant factors. Okay, now we need to look at the checklist for monitoring effective breastfeeding and adequate intake in a newborn infant. Okay, how do you know that a newborn infant is getting enough breast milk? In your MCCQE1 exam, in your PLAB exam, in your USMLE exam, in your AMC exam, Australian Medical Council exam, how do you know that an infant is getting enough breast milk? Let's dive into some questions. You have a 3-day-old preterm infant who is brought for follow-up after hospital discharge. The mother is exclusively breastfeeding but expresses concern that the baby seems fussy and is not stooling well. Examination reveals dry mucous membranes, reduced skin turgor, and only one wet diaper in the last 24 hours. The infant's weight loss is 9% from the birth weight, which on the following is the most appropriate next step in management. A, reassure the mother that breastfeeding adequacy improves over time. B, encourage more frequent breastfeeding and closely monitor urine output. C, supplement with formula and reevaluate weight gain in 24 hours. D, perform a complete sepsis workup, including blood cultures and lumbar puncture. And E, start IV fluids immediately due to dehydration. Doctors, please don't forget to subscribe to our YouTube channel. Please don't forget to subscribe. Please don't forget to subscribe. Don't forget to subscribe to our YouTube channel so we can grow the channel with you. Okay. And when you do that, it helps other doctors to also see it. This is open source information for everybody. So please, all we are asking is please just subscribe so that other doctors can also benefit from your subscription, because the more you subscribe, then YouTube shares the algorithm with other people and they can also see it. Okay. All right. So, what's the correct answer here? What's the correct answer? I see a lot of people going for B. Some are also going for E. So it looks like there's a battle between B and E. Battle between B and E. And the correct answer is C. You want to supplement with formula. Now, so you want to supplement the formula and reevaluate the child in 24 hours. So signs of dehydration in neonates include, number one, wet diaper. Remember that I was talking about the fact that we are very careful with adding formula. However, two things which can at times lead us to start formula. Number one, hypoglycemia. Number two, signs of dehydration. Okay. Now, so this question was testing your knowledge on signs of dehydration in a newborn. So the signs of dehydration in neonates include few wet diapers, dry mucous membranes, and weight loss of more than 7 to 10%. This baby's weight loss is about 9%. Okay, so you know it's an exam question trick where instead of me saying the child is dehydrated, I rather put in the percentage, and we are expecting the candidate to know what percentage of weight loss indicates dehydration. And we learned that if the baby is dehydrated, then you want to add some formula. Okay. And this baby's weight loss, I want to share the question again, was 9%. 9%. All right. 9%. 9%. Yes. So I have this point from Dr. Marian. I was expecting, it says during the first week, a newborn is expected to have weight loss between 5 to 10%. Doc, it's not even during the first, it is during the first 2 weeks. It's in the first 2 weeks. But look at the precipitous loss in weight in just 3 days. In just 3 days. That's where the problem is coming from. Remember, the question says it's a 3-day term infant, right? So you're expecting that 5 to 10% weight loss because of like their large surface area and the fact that they have a lot of water in their body. You know, they will lose a lot of fluid in the first 2 weeks, and then they start gaining it. But in the first 3 days, this baby has already lost 9%. That's where the problem is coming from. And a sign of dehydration is if, you know, the baby loses precipitous amount of weight, about 7 to 10% of the weight in the first few days. That's where the problem comes from. Okay. So signs of dehydration, again, few wet diapers, dry mucous membranes, weight loss of more than 7 to 10%. Why are the rest of the answers wrong? Reassurance is inappropriate, as dehydration the baby can be dangerous. Okay, and increasing breastfeeding alone may not be enough if milk intake has been consistently inadequate, because you are telling the mother to give more from an empty tank and she cannot give any more. Okay, and a sepsis workup is unnecessary unless there are infection-related symptoms like temperature instability. And IV fluids are not the first line management unless dehydration is very severe. Okay, next question. A 4-day full-term infant presents for routine newborn follow-up. The mother states that she's been breastfeeding every 3 to 4 hours, but she's unsure if the baby is getting enough milk. On examination, the baby is alert with moist mucous membranes and normal skin turgor. The mother reports that the baby is having at least 6 wet diapers and 3 stools per day. Which of the following findings would indicate that breastfeeding is effective? A, audible swallowing during feeds. B, weight loss of 12% since birth. C, sleeping for long periods without waking for feeds. D, persistent jaundice at day 4. And E, feeding fewer than 6 times in 24 hours. Which of the following findings would indicate that breastfeeding is effective? Effective breastfeeding. How do you know that breastfeeding is effective? Is it A? Is it B? Is it C? Is it D? Is it E? Dr. Saha said C. Dr. Gloria says A. Dr. God's Favor says C. Dr. Maria says C. Yes.
I want to play in the snow.
Okay, go upstairs. I'll be with you very soon, okay? And then we're going to play in the snow, okay? Go. I'll be with you. Okay. So what's the correct answer? The correct answer is A. A. How do you know that a child is feeding well? A, they have audible swallowing during feeds. Now, sleeping excessively, because I saw a lot of people going for C as well. Sleeping excessively without waking for feed is a sign of poor feeding. It's a sign of poor feeding. It's a sign of poor feeding. Okay? Now, weight loss of more than 10% is concerning and suggests inadequate intake. And persistent jaundice could indicate breastfeeding jaundice or dehydration. And feeding fewer than 6 times in 24 hours is inadequate. Usually in 24 hours, this is another thing you want to note. Usually in 24 hours, you want to see that the baby is feeding between 8 to 12 times. Because you want them to feed on demand. But if you want to count, you want them to feed at least 8 to 12 times in 24 hours. Okay, next question. A 32-week preterm infant is being managed in the NICU. The mother wishes to breastfeed, but the baby has difficulty latching and suckling due to neurologic immaturity. Which of the following is the best strategy to ensure adequate milk intake for this preterm infant? A, encourage skin-to-skin contact, but delay feeding until the baby can latch. B, provide formula supplementation until the infant reaches term gestational age. C, have the mother express breast milk by hand or pump at least 8 times in 24 hours. D, wait for the infant suckling reflex to develop before introducing breast milk. And E, discharge the infant once they demonstrate ability to latch regardless of weight gain. What's the correct answer? The correct answer is C. You want to have the mother to express breast milk. Dr. Henry, I see your answer. You want to encourage have the mother to express breast milk by hand or pump at least 8 times in 24 hours. And the explanation is very simple. Preterm infants may be unable to latch and suck effectively. So mothers should express breast milk by hand or pump to maintain supply. Okay? And delaying feeding risks poor nutrition and hypoglycemia. And formula is not necessary unless maternal milk supply is insufficient. Okay? And waiting for the suck reflex delays nutrition, and that can lead to weight loss, and that can lead to hypoglycemia. Okay? And weight gain is an essential discharge criterion. So you don't say that I'm going to let the mother go home despite the weight. If the child is losing weight, keep the baby till the baby starts gaining appropriate weight, and then you can discharge home. Next question. You have a 28-year-old first-time mother presents with severe nipple pain and cracked nipples after each breastfeeding session. The infant 5 days old feeds frequently but appears fussy after feeds. The mother reports no audible swallowing during feeds. What's the most likely cause of this breastfeeding difficulty? A. Inadequate latch, leading to ineffective milk transfer. B. Normal newborn behavior that will resolve with time. C. Maternal yeast infection requiring antifungal treatment. D. Overproduction of breast milk causing forceful letdown. E. Maternal anxiety causing reduced milk letdown. What's the correct answer? Dr. Henry went for A. Dr. Maria Fernandez Vasquez also went for A. A lot of doctors are going for A, and the answer is A. Inadequate latching leading to ineffective milk transfer. And, that can, poor latch. Like when we say latch, that is the baby's mouth holding onto the nipple effectively. Poor latch causes nipple trauma and inefficient milk transfer, and it leads to frequent but ineffective feeding. Okay, so that is the issue with latching. And this is not normal behavior. Pain and fussiness indicates that there's a problem. If the mother is having pain after breastfeeding, and if the baby is having fussy behavior after breastfeeding, that means there's a problem. And yeast infection causes deep burning pain, not just cracked nipples. So if you are preparing for your MCCQE1, how do you pick up a case of yeast infection on the nipple? Don't just look for cracked nipples. Look for a patient with deep nipple pain. Okay. Next question. Your 3-year-old infant presents for routine follow-up. The mother states that the baby feeds only 4 times in 24 hours, but appears sleepy and calm. The baby has mild jaundice, and examination shows decreased skin turgor and dry mucous membranes. What's the most appropriate next step? What's the most appropriate next step? A. Reassure the mother that some newborns feed less frequently. B. Encourage breastfeeding at least 8 times in 24 hours and monitor output. C. Supplement with formula and instruct the mother to breastfeed less often. D. Perform liver function tests to evaluate the cause of jaundice. And E. Advise the mother to wake the baby for feeds only if they appear hungry. And the correct answer is B. Encourage breastfeeding at least 8 times in 24 hours. Remember, we said that the baby should breastfeed at least 8 to 12 times in 24 hours and monitor the output. The answer is B. Feeding at least 8 to 12 times per day ensures adequate hydration and weight gain. It ensures adequate hydration and weight gain. And feeding only 4 times per day is inadequate and can lead to dehydration and jaundice, right? So probably that's why the baby is jaundiced. And formula is not necessary unless intake remains inadequate, despite breastfeeding support. Okay, and physiologic jaundice is common. Increasing feeding frequency helps clear bilirubin. All right, and newborns should be woken for feeds if they do not wake up on their own. But remember, the first principle is feeding on demand, and then you want to look at the total number of times the baby is feeding in a 24-hour period, between 8 to 12 times. If the baby is not feeding on demand and is not waking up 8 to 12 times to feed, you want to wake the baby up to feed the baby. So, doctors, please, is that okay? Is that too much information about breastfeeding alone? So you realize that approach to newborn assessment, this is just breastfeeding. And we've done almost 1 hour 40 minutes. 1 hour 40 minutes, right? We've done almost 1 hour 40 minutes. Please, do you want us to continue or you want us to hold on? Should we continue? I want to know, should we continue or we should hold on? Okay. So it looks like some doctors want us to continue, so we'll continue. Okay. So, how do you know that an infant is getting enough breast milk? Number one, remember the word at least. I didn't say one void. At least one void per day of age. So if they are one day, you expect them to pee at least one time. At least. So it is one void per day of age. So if they are 2 days, you expect them to pee at least two times. At least. That is the least amount. And at least once 2 per day. So by 5 days, they should pee at least 5 times per day, at least, and at least once 2 per day. Okay, so it is for the voiding, it is one void per day of age. Doctors, please, are we all on the same page? It is one void per day of age. So if they are 7 days, or if they are 7 days, you want to see that they've peed at least 7 times. And then there's stool at least one stool per day, at least. Okay, so that means they can do more. How do you know an infant is being breastfed well or is adequately hydrated? They have moist mucous membranes and their skin tegel is normal. Then the weight loss is within normal limits. Okay, for delivery type and feeding method. And then they feed at the breast or mother expresses colostrum within 2 hours after birth. And this baby wakes up frequently to feed and appears content after feeding. So they don't look fussy. They are not still crying after feeding. They look content. They'll just sleep. Okay, they'll just sleep. And you can also hear audible swallowing when they are breastfeeding. And they feed at least 8 times in 24 hours. At least. Look at those numbers very well. You want them to hit 8 to 12 times. But the least number of times a baby should breastfeed should be 8 times in 24 hours. What are the maternal signs that the baby is breastfeeding well? The mother will not be experiencing nipple pain or nipple compression. There is evidence of colostrum on the baby's mouth. Okay, or to be coming from the nipple. If infant is not consistently latching, mother is expressing milk by hand or pump at least 8 times in 24 hours. And if infant is preterm, mother is expressing with each feeding at least 8 times in 24 hours. So these are the maternal signs and practices that enhances adequate breastfeeding. Okay, now let's move from this to breastfeeding and medications. Breastfeeding and medications. Remember MCCQE1. MCCQE1. You need to know your stuff. So breastfeeding and medications. Let's get into that. Okay, we're going to do some questions on that. You have a 28-year-old woman who had a cesarean delivery 5 days ago, presents for postpartum visit. She reports persistent incisional pain, but wants to continue exclusive breastfeeding. She asks for pain relief that is safe during breastfeeding. This is something very, very critical that you need to know. Medications which are safe and medications which are contraindicated. So which of the following is the most appropriate analgesic choice for this patient? A, acetaminophen. B, codeine. C, tramadol. D, oxycodone. E, morphine. We are looking for the most appropriate analgesic choice for a mother oh, look at what this doctor just said something. He said, Dr. Gamagi Pebotuwe says, you fed us well today in an unforgettable way. Doc, if you think I'm feeding you well today, then you don't know what is happening in MedCognito. We are really feeding them well, and when they are done, they go to sleep. We are really feeding them well. So if you want to be part of it, that's great, So, and that's exactly what we do during the med drills. That's what we do during the class. Tonight, you have a class. So MedCognito candidates, please don't forget, don't get tired. After this, get some sleep. You have another class tonight, right? I think it's a class on, is it ethics? Yeah, I'll just check it for you. I think it's a class on ethics. So if you think we are feeding you, don't forget. You have a class here, Ethics 2, at 6 p.m., 6:30 p.m. EST tonight, okay? And you can join. If you want to join, let me know. Send me a message. We'll give you access to join that class, okay? So, which of the following is the most appropriate analgesic of choice? The answer is A, acetaminophen, okay? So, acetaminophen and NSAIDs are safe during breastfeeding. Remember that NSAIDs, you want to hold on with NSAIDs in the third trimester because you want to prevent premature closure of the patent ductus arteriosus. But when the baby is born, NSAIDs can be given. Okay? B, C, D, and E. Let's go back. Codeine, tramadol, oxycodone, and morphine. These are opioids. Okay? And they can cause neonatal sedation, respiratory depression, and poor feeding. Okay, so morphine can be used in short courses, but it's not a first line choice. All right, and codeine should be avoided due to variability in CYP2D6 metabolism, which may lead to excessive morphine levels in breast milk. So if you have Tylenol and ibuprofen and you also have morphine, go with Tylenol and ibuprofen first. All right, yeah. So the candidates say that today they have ethics 2. Okay, ethics 2. Okay. So, next question. You have a 32-year-old woman with a history of major depressive disorder in 3 weeks postpartum. She was previously stable on fluoxetine but discontinued it during pregnancy. She now reports low energy, anhedonia, and feelings of guilt about being a bad mother. She wants to restart her medication but is concerned about breastfeeding safety. Which of the following is the best recommendation? A, restart fluoxetine. B, start paroxetine instead of fluoxetine. C, use lithium as it is more effective for postpartum depression. D, initiate bromocriptine to suppress lactation and then start antidepressants. And E, recommend discontinued breastfeeding and start fluoxetine. What's the correct answer? What's the correct answer? What's the correct answer? Are you going to restart fluoxetine or are you going to start paroxetine instead of fluoxetine? Or are you going to use lithium? What's the correct answer? The correct answer is restart fluoxetine. Fluoxetine, along with sertraline and tricyclic antidepressants, is safe during breastfeeding. Okay, paroxetine is also safe, but fluoxetine can be continued if it was previously effective. You can continue that. And lithium, please write it down. It's contraindicated. Please write this down. Lithium is contraindicated in breastfeeding due to neonatal toxicity. Okay, and bromocriptine is contraindicated due to its association with sudden cardiovascular events and lactation suppression. So bromocriptine can suppress breastfeeding, and it can also have cardiovascular events. Okay, and discontinuing breastfeeding is unnecessary. Fluoxetine is safe. Okay, so doctors, you need to know fluoxetine. You have to know medications which are safe and medications which are not safe. Okay, next question. A 30-year-old woman with bipolar disorder is 4 weeks postpartum and breastfeeding her newborn. She's currently well, but is concerned about relapse. Her psychiatrist is considering restarting her mood stabilizer. Which of the following should be avoided? A, during breastfeeding. A, carbamazepine. B, valproic acid. C, lamotrigine. D, lithium. E, phenytoin. Which of the following should be avoided during breastfeeding? Which of the following should be avoided during breastfeeding? This one, we talked about it in the last question. So the answer is D, right? Lithium. Lithium is contraindicated in pregnancy in breastfeeding due to the risk of neonatal toxicity. And how does it present? Neonatal toxicity of lithium: hypotonia, lethargy, nephrogenic diabetes insipidus, thyroid dysfunction, and arrhythmias. Okay, that is lithium for you. Carbamazepine, valproic acid, lamotrigine, phenytoin are generally safe during pregnancy. Doctors, please write these down. This is very, very important. Okay, yep, a 26-year-old woman with pyelonephritis admitted for IV antibiotics. She's exclusively breastfeeding for her 2-month-old infant and asks which antibiotics are safe. Which of the following antibiotics is contraindicated during breastfeeding? A, penicillin. B, cephalosporins. C, nitrofurantoin. D, aminoglycosides. E, chloramphenicol. Which of the antibiotics is contraindicated during breastfeeding? So now we are going a bit deep. We are going deep. So someone is saying D. Some is also saying E. Dr. Thomas Janet says E. What's the correct answer? The correct answer is E, chloramphenicol. So chloramphenicol is contraindicated due to the risk of bone marrow suppression leading to gray baby syndrome. Okay, so think chloramphenicol, gray baby syndrome. Chloramphenicol, gray baby syndrome. Okay, chloramphenicol, gray baby syndrome. Penicillin, cephalosporins, and aminoglycosides are safe. Nitrofurantoin should be avoided in infants with G6PD deficiency due to the risk of hemolysis. That is C, right? Okay. Next one. Don't forget, I'll go deep into the medications which are contraindicated. A 34-year-old woman who delivered 6 weeks ago is exclusively breastfeeding and wants contraception. She does not want an intrauterine device and prefers oral contraception. Okay, which of the following is the best choice? A, combined oral contraceptive pills, OCPs. B, progestin only pills. C, copper intrauterine device. D, depot medroxyprogesterone acetate, DMPA. And E, bromocriptine. Which of the following is the best choice? Is it A? Is it B? Is it C? Is it D? Or is it E? Which of the following is the best choice? 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 So the correct answer is progestin only pills. Let's go back to the question. Look at the question very well again. So those who are going for copper IUD and those who are going for D, be very careful, right? It says, patient is a 34-year-old woman who delivered 6 weeks ago. She's exclusively breastfeeding and wants contraception, right? She does not want an intrauterine device and prefers oral contraception. So that means that it makes C and D wrong. Oral contraception makes C and D wrong. Copper IUD is not oral. D is depot medroxyprogesterone acetate. That's also an injection. So those two are wrong. Bromocriptine will rather reduce breast milk production. So you're left with combined oral contraceptive pills and progestin-only pills. And the answer is progestin-only pills. Progestin-only pills do not suppress lactation and are preferred. Okay? Combined oral contraceptive pills contain estrogen, and these may decrease milk production. Doctors, please, did it make sense? Please. Okay. So now let's look at the medications which are safe during pregnancy. I'm just going to run through them quickly. A, for analgesics, acetaminophen and NSAIDs. Okay. Dr. Bright is asking a question. He says, Dr. Brony, what happens to lactational amenorrhea? Would it not be sufficient in this case? Well, lactational amenorrhea can help, but that will mean that the mother should be breastfeeding all the time. She should be doing exclusive breastfeeding. But the question did not even ask about lactational amenorrhea, doctor. So you all the time, you want to make sure that you are focused on what the question is actually saying, right? Okay, Dr. Bright, I hope I've answered your question. So analgesics, which are safe during pregnancy, acetaminophen and NSAIDs. Anticoagulants, which are safe, heparin. Antidepressants, which are safe, sertraline, fluoxetine, tricyclic antidepressants. Okay, anti-epileptics, which are safe. Doctors, this slide is very, 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 very important. Okay, so please kindly pay attention to it. So anti-epileptics, which are safe, can be phenytoin, carbamazepine, and valproic acid. Antihistamines are also safe. Antimicrobials, which are safe, are penicillins, aminoglycosides, cephalosporins. Beta-adrenergic agents, which are safe, propranolol and labetalol. Insulin is safe. Steroids are safe. Oral contraceptive pills, low dose, although estrogen-containing oral contraceptive pills may decrease breast milk production. So if you are torn between progestin only and estrogen-based oral contraceptives, please go with estrogen-based oral contraceptive pills. Doctors, are we all tracking together? Please. I want to know whether you are tracking together. Please, kindly make sure that you've written down all these points. Please, kindly make sure that you've written down all these points because this is very important. You can't miss this in a board exam. Medications which are safe during pregnancy. Medications which are safe. Now, let's look at medications which are contraindicated in pregnancy. Number one, chloramphenicol. It can lead to bone marrow suppression. Number two, cyclophosphamide. It can lead to immune system suppression. Number three, sulfonamides, especially in G6PD deficiency. It can lead to hemolysis, right? As well as nitrofurantoin, especially in G6PD deficiency. That can also lead to hemolysis. So if the baby has glucose 6-phosphate G6PD deficiency and you give them nitrofurantoin, it can lead to hemolysis. Tetracycline, lithium is also contraindicated. Phenandione is also contraindicated. Bromocriptine, it will reduce breast milk production. Anti-cancer and immunosuppressive medications and psychotropic drugs, they are relative contraindicated. Okay, relative contraindications. Doctors, please don't forget to hit on the like and the subscribe button on our YouTube channel. Hit on the like and the subscribe button, and let's move it from there. YouTube channel, hit on the like and the subscribe button. So, know the medications which are safe, know those which are not safe. So, before we go to the last part of the class, I want to just let you know that for the med drill on February 19th, psychiatry, we did the first part. We recovered 32 topics. This last part will be brushing everything up. Okay, whether you're a MedCognito candidate or you're not a MedCognito candidate, you still have access to it. Okay, but for those who are MedCognito candidates, you get access to, like, you get a replays in your Sprint portal, you get your live lecture recordings, everything is there for you. You get your extensive study resources, you get your comprehensive practice mock exams, more than 1,000 mock exams for you to do at home on your own. And then in March, we will do the live mock exams where there is an invigilator who will be watching over you and will put you in an exam situation. Okay? And of course, if you think that you are being fed on this call, then you don't know what is happening in MedCognito itself, like the candidates, right? So it's wonderful, and I want you to really, really know that this is what we have for you. You can get access to everything in MedCognito for even just $450 for just 1 month. For 1 month only, for just $450. Okay? And if you want to have access for 6 months, you can either pay one time, that is $2,199, and with that you save about $400, or you can decide to pay $420 every month for 6 months, or you can even decide to pay it over 2 months, over 3 months. Okay, and I know that the exam is coming up and others are going for May, and some people may want just 3 months access. So we've also made an option for you. For just $1,350, you can get access to everything in MedCognito for 3 months. Okay, so doctors, there are so many options. You want it for a month, you want it for a month by month, for 4 months, you want it for 6 months. Whichever option you like is there for you. Okay, just send me a message right now after the class, because people are sending messages. I'll give you a call and then we can talk through the plan for you, an individualized plan. Okay, whether you want just for 1 month to even try what is MedCognito all about. All right, if you want 3 months as well, we are there for you. Okay, so I'll share the link in the comment section. If you want 1 month, I'll share the link. If you want 6 months as well, I'll share the link with you. Okay, and then you can use that to get into the portal. I'm sharing the link in the Facebook and the YouTube conversation, and then the class can continue, and then we'll jump to the last part of the class. Okay, so I'm sending the link. You can see the link, and yeah. Okay, all right. So, and then don't forget, you can get in touch with me at +1 306 891 5649. Okay, so inadequate breastfeeding. Let's go through this question. You have a 2-week-old term infant who is brought to the clinic for routine checkup. The mother is exclusively breastfeeding but expresses concern that her baby is sleeping long hours and does not seem eager to feed. The baby has only 4 wet diapers per day and has not yet regained birth weight. On examination, the infant appears slightly jaundiced but otherwise well. Which of the following is the most appropriate next step? Dr. Irene says I should repeat my number. My phone number is what is scrolling at the bottom of the screen. It is +1 306 891 5649. +1 306 891 5649. Okay. I'm sharing it in the comment section as well. So, which of the following is the most appropriate next step? Reassure the mother and schedule a follow-up in 2 weeks. Encourage increased breastfeeding frequency and reassess weight in 2 to 48 hours. Supplement immediately with formula and discontinue breastfeeding. Perform a liver function test to evaluate for neonatal hepatitis and discharge home and advise feeding on demand only. So those who want my phone number, that is what is on the screen right now. +1 306 891 5649. Okay. As soon as the class is done, jump on a call with me. Let's have a personalized plan for you. Okay. So the correct answer is you want to encourage increased breastfeeding. That's B, frequency, and reassess weight in 24 to 48 hours. So the signs of inadequate intake include less than 6 wet diapers per day, excessive sleepiness, jaundice, and failure to regain birth weight by 10 to 14 days. So that's what we're discussing. When people were asking, okay, Dr. Boniba, we thought that the infant has to lose some weight. Yes, but then they have to regain their birth weight by 10 to 14 days. Okay. But for someone to lose about 9% of their weight by day 3 is not good. Okay. So increased breastfeeding frequency is a first line intervention before considering supplementation. Okay. Next question. You have a 3-week-old exclusively breastfed infant is brought in for routine visit. The parent asks whether they should be given any vitamin supplementation to their baby. The baby is gaining weight appropriately and has no concerning symptoms. Which of the following is the best recommendation? A, no supplementation is necessary in a fully breastfed baby. B, give 10 micrograms, that is 400 international units of vitamin D daily, starting immediately. C, wait until the baby starts solid foods to introduce vitamin D. D, advise high-dose maternal vitamin D instead of infant supplementation. And E, recommend increasing breastfeeding frequency instead of supplementation. What's the correct answer? What's the correct answer? Is it A? Is it B? Is it C? Is it D? Is it E? Ha ha ha. So the correct answer is B. You want to give 400 international units of vitamin D starting immediately. All exclusively breastfed infants need vitamin D supplementation starting in the first few days after birth. That is the teaching in Canada. We want to give them some vitamin D so that they can get going. Okay. And breast milk does not provide sufficient vitamin D. Okay. And waiting until solid foods is inappropriate. And maternal supplementation requires 6,400 international units to provide adequate vitamin D in breast milk. So if you are giving only 2,000 units, that is not good. And increasing breastfeeding alone does not improve vitamin D levels. So give at least 400 international units of vitamin D a day to the infant. Okay. A 5-day-old newborn is exclusively breastfed. Mother reports that the baby wants to suck constantly and asks whether she should introduce a pacifier to soothe the baby between feeds. She's exhausted and unsure if the baby is getting enough milk. What's the best response to the mother's concern? A. It is best to avoid pacifiers for the first 2 to 4 weeks until breastfeeding is well established. B. Pacifiers should be introduced immediately to prevent sudden infant death syndrome. C. If the baby wants to suck, it likely means they are getting enough breast milk, so a pacifier can be given. D. Use the pacifier between feeds to train the baby's oral conditioning. And E. It is best to stop breastfeeding at night and use a pacifier so that the baby can sleep longer. What's the correct answer? Is it A? Is it B? Is it C? Is it D? Or is it E? And I can see a lot of people are going for A. So A is the correct answer. It is best to avoid pacifiers for the first 2 to 4 weeks until breastfeeding is well established. We all know that pacifiers reduce the risk of sudden infant death syndrome, but early introduction of pacifiers may interfere with feeding cues and milk supply. Right? So you want to make sure that breastfeeding is established. Then you can use your pacifiers. Next one. A 12-day-old full-term infant presents with increased sleepiness and poor feeding. The mother reports that the baby rarely wakes up for feeds and has been sleeping for 6 to 7 hour stretches at night. The baby has had only 5 wet diapers per day. Examination reveals mild jaundice and weight loss of 11% from birth weight. This is a 12-day-old infant. Which of the following is the most likely explanation for this infant's condition? A. Physiologic newborn sleep pattern. B. Normal variation in feeding habits. C. Inadequate milk intake and possible dehydration. D. Congenital hypothyroidism. And E. Neonatal sepsis. What's the correct answer, doctors? What's the correct answer, doctors? So the answer is correct, C. A lot of doctors are going for C. So it's inadequate milk intake and possible dehydration, okay? So signs of inadequate intake include sleepiness. The child is sleepy throughout the whole day, less than 6 wet diapers per day, jaundice and weight loss of more than 10%. And sleeping throughout the night before 6 weeks is abnormal in a healthy newborn, all right? And hypothyroidism is rare and would cause persistent jaundice, poor tone. You have poor tone and constipation. And neonatal sepsis would present with fever, poor tone, and respiratory distress, not just sleepiness. All right? Okay. Next question. A 6-week-old infant is brought in for routine checkup. The mother asks whether she can start using a pacifier at night to help the baby sleep. The infant has good weight, feeds well every 2 to 3 hours, and is effectively draining the breast. What's the best response? A. Since breastfeeding is well established, you can introduce a pacifier for sleep. B. Pacifiers should always be avoided in breastfed infants. C. Introduce a pacifier only after baby starts solid foods at 6 months. D. Pacifiers should only be used if the baby refuses to breastfeed. And E. Since baby sleeps well, pacifiers are unnecessary. So, doctors, what's the correct answer? What's the correct answer? Can see a lot of doctors are going for A, and A is correct. So since breastfeeding is well established, you can introduce pacifier, okay? And we're talking about the fact that pacifiers can help reduce the risk of SIDS, okay? Sudden infant death syndrome. So let's do a deep dive into inadequate breastfeeding and pacifier use. How to know if a baby is inadequately breastfed? They have less than 6 wet diapers per day. After the first week, please. Number 2, they have less than 7 feeds per day. We said that the adequacy of the feeds should be at least 8 to 12. Okay. Next one, they are sleepy or lethargic. And then they have weight loss of more than 10% of birth weight past their 10 to 14 days. Because by 10 to 14 days, they should be regaining their birth weight. Okay. And then jaundice. So these are the signs of a baby who is inadequately breastfed. A baby who is inadequately breastfed. These are the signs. 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 Less than 6 wet diapers per day. Less than 7 wet feeds per day. Sleepy infants, lethargic infants, weight loss of more than 10% of birth weight, and jaundice. Let's talk about pacifier use since we talked about it extensively. In the first 2 to 4 weeks, pacifier use may interfere with breastfeeding establishment. So, offer the breast for sucking instead of pacifier to encourage frequent feeding and stimulate milk production. After breastfeeding is well established, that is when pacifiers can be introduced for sleep to reduce the risk of sudden infant death syndrome. When do you introduce pacifiers? After breastfeeding is well established. Don't give pacifiers on the first day, doctors. If you see that, run away. Now let's look at maternal contraindications to breastfeeding. So we have absolute contraindications and we have relative contraindications. So absolute contraindications, if the mother has HIV, don't encourage breastfeeding. If they have HTLV1 and HTLV2, don't. And as well, if the baby has infant galactosemia, that is why in Canada, as soon as the baby is born, there's a heel prick done to get blood work, and then they screen for all these like galactosemia, right? Because if the child has galactosemia and then the mother breastfeeds, mine, oh mine, that is trouble, right? What are the relative contraindications for breastfeeding? Chemotherapy, radioactive compounds, or certain medications which are known to cross the breast milk with neonatal effects. So we have absolute contraindications and relative contraindications, okay? And if the mother has active untreated tuberculosis in the first 2 weeks of life, as well as if there's active herpes simplex virus 2 lesions on the breast. So usually if they have active herpes simplex 2 lesions on the breast, expressed breast milk from the unaffected breast can still be fed to the baby. But with where there is the herpes, you don't want to give the kid. Why? Because if you give it and then the kid contracts herpes, don't forget that it can lead to encephalitis. Okay, it can lead to encephalitis. And then oral contraceptive pills and breastfeeding. We talked about that, but I want to hit on it again. Oral contraceptive pills are not contraindicated. However, the combined oral contraceptive pills, especially because of the estrogen content, may decrease lactation, but is not dangerous to infants. So please remember that. Oral contraceptive pills can decrease lactation, but it's not dangerous to infants. Doctors, ladies and gentlemen, awesome Facebook and YouTube friends, I think it's time we bring the curtain down on the class. It's been an awesome 2 hours, 15 minutes of reviewing this very important topic. Doctors, let no one lie to you. The MCCQE1 is a very, very extensive exam. And that is why I am here with our team. We have committed ourselves to make sure that whatever it is that we can do to get you to the finish line, we'll do it. My number is there, +1 306 891 5649. Doctors, reach out. Reach out. Some of you are burdened. You don't know how to start. You don't even know how to go around it. Reach out. That is why I'm here. After this, I'm going to take a couple of calls and then we'll spend time with the family. Please, reach out. Reach out. It was a great participation in class. You may, breastfeeding. No. Doctors, there's more to breastfeeding than you think for the MCQ1 exam. Breastfeeding alone, we've done it in 2 hours, 15 minutes. Reach out. Okay? Reach out. So, someone says, thanks so much, Dr. Brony. Please, what's the basics behind vitamin D supplementation in infants? You want to prevent vitamin D deficiency, especially in Canada, right? You want to prevent vitamin D deficiency because it can affect their neurodevelopment. Doctors, reach out right away. I'll be picking up some calls. +1 306 891 5649. Reach out. Okay? Thank you very much. Those in MedCognito, you have a class at 6:30 p.m. EST. So that means in about 2 hours, you have another 3-hour class. And if you're not in MedCognito and you want to join the class, you can even just register for a month and we'll send you the link right away. So you can join the class. Okay? You can also use the 6 months package. You can use the 3 months package. +1 306 891 5649. Reach out right now and I'll be ready to talk to you. When you reach out to this number, it is my own phone number. This is the phone I use. Okay? It's my own phone number. So please reach out right now. If you have any doubts, reach out. I'll help you to clear your doubts so that you can effect good preparation for your MCQ1 exam. Doctors, thank you very much for spending your day with me. I'm out of here. Stay safe. +1 306 891 5649. That is my phone number. Doctors, all the best. Bye-bye.